All right, guys, welcome to Grand Rounds Conference this week. Before we get started, I just wanted to remind everyone for our non-regular attendees, if you want to claim CME credit, there's a form that we have in the back. Some of you might have already gotten it. Just record your CME code on there. The code's written up here, 36545, and then it has instructions on how to claim that credit. Thank you. There's an app. You can text as well, so very high-tech stuff here. Well, again, welcome to Grand Rounds. We've got an excellent discussion today. I'd like to go ahead and get started by introducing our four speakers today. Starting off is Armando Nahum. Armando is the co-founder and president of Safe Care Campaign, an organization dedicated to infection prevention and a principal of the Healthcare and Patient Partnership Institute. Armando currently sits on the CDC Council on Infection Prevention, the Georgia Hospital Association Advisory Board to Prevent Infection, the Georgia Department of Public Health HAI Advisory Committee, and is a member of the MedStar Health System Patient and Family Advisory Council for Quality and Safety. Armando is the Patient and Family Advisor for MedStar Health Sepsis System Initiative. Through his work, he has been instrumental in passing legislation in Maryland, producing a sepsis video for patients and family education, and for reducing mortality to 35% within that system. He is a winner of the Sherman Award, as well as the Circle of Honor for Patient Safety Innovation from the Maryland Patient Safety Center. He has also, most recently, been sworn into the White House to serve a 4-year term as a voting member on the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria. Armando is the director for the Center of Engaging Patients as partners at MedStar Institute for Quality and Safety as well. Our second speaker is Dr. Robert Hughes. Robert Hughes has the privilege of serving as the chair of the University Hospital System Sepsis Initiative. A graduate of Lake Erie College of Osteopathic Medicine, he completed his training in emergency medicine at University Hospitals in 2013 and joined as clinical faculty. He currently serves as the Associate Medical Director of the Cleveland Medical Center, as well as the Medical Director of Clinical Observation Medicine and Advanced Practice Providers. Our third speaker is Kathy Rochow. Kathy joined the Acute Care Patient and Family Partnership Council in 2016 to partner with Cleveland Medical Center in patient safety. In 2018, she joined the Sepsis and Rapid Response Performance Improvement Initiative at UHCMC within the UH Quality Institute, offering the patient and family perspective. Kathy has shared her experiences at CMC's Management Forum, the Ohio Hospital Association, and Barrel Institute webinars as well. She continues to share her story to bring positive impact to patient safety. And lastly, joining us is Dr. William Brien, who joined University Hospitals in Cleveland as the Chief Medical Officer and Chief Quality Officer for the system in December 2017. He currently oversees provider initiatives across the system, including high reliability medicine, quality and safety, patient advocacy, physician relations, and utilization and case management. Dr. Brien is a renowned physician, researcher, and administrative leader with 3 decades of experience as an orthopedic surgeon. He comes to UH from Baylor St. Luke's Medical Center in Houston, where he served as Senior Vice President of Medical Operations and was the Chief Clinical Officer since 2015. He was also a clinical professor of orthopedic surgery at Baylor College of Medicine. Prior to that, Dr. Brien held numerous clinical and leadership positions at Cedars-Sinai Medical Center in Los Angeles for 21 years. From 2007 to 2015, he was Professor of Surgery and Executive Vice Chairman in the Department of Surgery. He also served as director of the Orthopedic Center since 2013. Dr. Brien earned his medical degree from the University of California, Los Angeles School of Medicine. He completed his orthopedic surgery residence at Los Angeles County University of Southern California Medical Center, and a fellowship in adult reconstructive surgery at the Hospital for Special Surgery in New York City. In addition to his hospital leadership roles, Dr. Brien served as the mayor of the city of Beverly Hills, California from 2012 and 2013. He also served as State Commissioner of the California Health Policy and Data Advisory Commission, and as a fellow and member of the Board of Counselors for the American Academy of Orthopedic Surgeons. All right, let's welcome our speakers. Sorry about that. Dr. Brien will not be joining us today.
Well, thank you so much for that introduction. It was so great. I'll come back tomorrow and do it again. First of all, hello, everyone. Thank you so much for having me here. It's truly an honor and a privilege to be here today. I remember being here about a year ago doing one of our studies across the country, and your hospital was one of them with great results. So thank you all for the work that you do. I really thank you for allowing me to share my family story with you and how important patient and family engagement really is in this work. You know, I believe in my heart. Is there a clicker? Yes, thank you. I believe in my heart that everyone here today profoundly cares about the patients that you treat within your organization, and that you want to work within a culture and an atmosphere that puts safety and puts your patients first. Unfortunately, though, my family has had 3 bad experiences as patients. They didn't feel like they were cared for properly. They didn't even feel like their best interest was taken into account or even their voices heard. You know, someone once said that in life, perhaps more than education, experience is sometimes the best teacher. Well, if that is true, I can tell you with all certainty that I don't know of anyone here in America today that has been more profoundly impacted by hospital-acquired infections than my own family. Because 3 members of my family were impacted in 3 different hospitals in 3 different states in 10 months' time, culminating with the death of my son, Josh. So I'm going to take you a little bit through a timeline so that you understand what happened. So that's my dad, Quint, who caught a bacterial pneumonia up in Rochester, New York, where I grew up. He suffered what they said was a mild heart attack. I didn't know there was such a thing, but I guess there is. And Dad acquired bacterial pneumonia about 6 days after he was sent home. And I learned this many, many years later, that his doctor was pretty cool back then because he prescribed a course of antibiotics, not bringing Dad back to the hospital. So Dad recovered completely. It was great. The second case was my wife, Victoria. And this goes back actually 6 years prior to the incident. So back in the year 2000, our kids were getting to be teenagers and older. And she approached me one day and she said she wanted to do, you know, just a little mini mommy makeover, you know, just that one thing. Well, that's not true. 2 things. I'm a very supportive husband. So I said, of course. So she found a board-certified surgeon, and she had the surgery. She was satisfied cosmetically. Excuse me. But months right after the surgery, she started experiencing some terrible things. So every afternoon, she would have mini fevers. You know, they're just enough to make you feel cruddy. And she would have rashes, burning pains in her joints. Her muscles would ache. And it became a joke in our house that, Mom can only go shopping for a couple hours in the morning because she just couldn't do an all-day shopping. And the kids thought that was funny. But she went to every single doctor you can think of, from rheumatologist to dermatologist to what happens as lay people, when we get something, we go to that particular doctor that can take care of that particular thing. Unfortunately, all these doctors do not communicate with each other. So pick an ologist, any ologist in the Atlanta area. I probably have written them a check. And so very frustrated for her health, she decided one day to enumerate all her symptoms in one sheet. And so I'm going to find a doctor that I'm just going to tell him all of my symptoms. Sure enough, she finds an Atlanta rheumatologist, and after spending a few minutes with her, he says, Victoria, you're not dying. I know exactly what happened to you. But we can't reverse it, so we're going to manage with medication. Here it comes. So massive dosage of gabapentin later. My wife is walking around like a zombie, and it just did not work. So she says, you know what? I know that this happened since I've had the implants, so I want them out. And every single doctor she went to kept saying, I don't get this. But they kept saying it's like toothpaste. You know, once it's out, you can't put it back in. You know, bullet out of the gun, it doesn't go back in. And I'm thinking, what has that got to do with it? My wife's thinking is if the breast implants caused the problem, taking them out is going to fix them. That's how we think. Not so true, because her immune system had already been compromised during the 6 years. So she finally found a doctor that would take the breast implant out, and on that day, guess what they found? Staph epi biofilm slathered all over her breast implant. That's been there for 6 years, sapping her strength and robbing her of good health in years that she would not get back. My wife survived, obviously. She's okay, but she is on massive dosage of medication. If she doesn't take it, she's bedridden. The third case is our son Josh. And Josh was putting himself through school for the second time, becoming a child psychologist. And he was a proud kid, wanted to put himself through school without mom and dad's help. And he was doing that with being a skydiver instructor. He had done so many jumps. He was really good at it. On Labor Day weekend of 2006, there was a cold air density problem that pushed his parachute inward and threw Josh to the ground 60 miles an hour. Josh jackknifed. He broke his left femur, and the helmet produced a contusion in the back of his head. Immediately, he was taken immediately to the emergency department, where they made a big deal, kind of a joke about everybody who skydives has a piece of titanium in them. And that was not the issue. The issue was the the contusion in the back of his head. So they had to perform what you call a ventric procedure. And does everybody know what that is here? Yes? Good. So they had to relieve the pressure on Josh's brain, and Josh awoke, and he was fine. We took the first flight out of Atlanta, because Josh is in Colorado. We're in Atlanta. And upon arrival over there, Josh is in ICU, and we ended up spending 6 weeks with him in ICU. He acquired 2 cases of MRSA, delirium, ICU psychosis, and Josh seemed to be on a good road to recover, because they came to us after 6 weeks and said, Mom and Dad, it's time to go home. Josh is going to go on the rehab facility, down the road. And he's got some work to do, but he'll be fine. Those words, he'll be fine, still resonate with me. 6 days into rehab, so we went back to Atlanta, and 6 days into rehab, 11:30 at night, we get the phone call from hell. His neurosurgeon is on the phone telling us that Josh spiked 103 fever at the rehab center. He coded, and the rehab is not equipped to handle cases like that, so they sent him back to the hospital he came from. And here's where the problem occurred. His neurosurgeon was more preoccupied on what is causing this bacteria to make Josh's brain swell again, so he decides to do a lumbar. Now, I learned this later because I'm not clinically trained, so I wouldn't know this. But I've spoken to enough neurosurgeons for the last 13 years to know this. The lumbar puncture was the last thing he should have done. Because it's like, let me do an example for you. It's like taking an orange and putting it in the cup, right? You drill a hole underneath, you suck part of the orange down. Well, guess what happened? He sucked Josh's brain down. C1 to C3 is damaged. Josh is now on a ventilator. So by the time we took the first flight out, again, we find Josh on a ventilator. And within short of a week, he's damaged all the way down to his thoracic. So now he is a ventilator-dependent quadriplegic. Josh died shortly of that because sepsis took a hold of him. So you know, you call it hospital infections, nosocomial infections, healthcare acquired infection, then they said you can't say that. It's healthcare associated infection. Truly, I really don't care what you call them. Call them whatever you want to. They're very, very bad news for everybody. I'm sure nobody here wants to see another father like me crying with his head in his hands. No hospital that I know wants to explain to parents why their child is dead from their care. Certainly no nurse that I've ever met wants to see another patient that they've cared for and gotten to know die. No doctor I've ever met wants to feel like he or she have failed in the treatment of their patient. And no administrator wants to fear that a lawsuit is on the way. But you know what, more importantly than that? No family wants to have to say goodbye to the ones they love so much. And so throughout my initial research, the papers, the abstract and the stories of the dead and dying, sometimes it felt to me like we were losing people right and left. After Josh died, the numbers were like staggering. I mean, I couldn't believe the numbers. We live in Atlanta, so we reached out to the CDC, and they were very gracious with us. They brought us in, and they met with us and told us the numbers, and I was just astounded. The average person out there does not know this until something bad happens. And here in this country, we tend to have this attitude of, well, you know, Ebola, oh yeah, but that only happens over there. Until it happens over here. And now we're facing with the coronavirus, right? And I'm thinking we have the ability to grow sheep from a single cell, and we cannot save our son from dying. Just couldn't do it. You know, when Josh was dying, I witnessed more than 70 of his friends take over the hospital lobby for 2 days. And the hospital was actually nice enough to let them stay there. They slept on the floor just to have their few minutes to say goodbye to the dear friends before he left. And everyone had their own stories, and I watched grown men tear up and say some beautiful, beautiful words to our son. But after his friends were done, I knew it was my turn to say goodbye to Josh. And I just could not move, because the entire time I stood there without sleep for 2 days and 2 nights on the other side of Josh's bed. And Josh, because he was on the ventilator and he was quadriplegic, his head was pointing in one direction, so he had to come in his periphery in order for him to actually see. So I stood on the other side with my hand on his leg. Then I knew he couldn't feel me, but when it was my turn to go and say goodbye, I just could not take that step. So I forced myself, and sure enough, I got there, and he smiled big, but then I had no words. You know, all the pep talk, all the years, you know, Josh, don't do this. Josh, don't ride the bike over there. Josh, don't jump over there. Now what do I say to a son? What do I say to a child who's dying? And I forced myself to open up my mouth, and just words came out that I had for Josh since he was born. I said, I love you so much. And Josh looked at me and smiled big, and he started doing something that he was scanning my face with his eyes. You know, starting my forehead all the way down to my chin. I don't know to this day why he did that, but maybe for a time and a place where we no longer could be together. I'll never know that. You know, my friends at the CDC, they tell me that it's quite common in healthcare to miss that one single component in the delivery of care. Not intentionally, but it does happen. And then that component escalates to an adverse event or even death. And there's a theory out there called the theory of sensitive dependence on initial condition. It sounds really complicated, but it's not. You all heard about the butterfly effect. They even made a movie about it. You've heard about the snowball that causes the avalanche. That's what that theory stands for. We call it change one thing, change everything. And to better illustrate what I'm talking about, watch this.
Valid eyewitness to the recent evolution of American healthcare. I am a safe care advocate national healthcare system and thousands of hospitals across the U.S. are failing patients who trust them to make them well. They are not effecting measurable change through a consistent commitment to patient safety, caring for patients through highest standards of always use best practices. Thousands of dedicated caregivers are following best practices, but nowhere is it written in stone that others have to. In 2006, our son died from an infection he caught from his medical care. Joshua died for nothing. I do not believe safety can truly and actually exist in America during our lifetime, solely and entirely because of the American healthcare system. Solely and entirely because of the American healthcare system, safety can truly and actually exist in America during our lifetime. I do not believe Joshua died for nothing. Our son died from an infection he caught from his medical care in 2006, but nowhere is it written in stone that others have to. Thousands of dedicated caregivers are following best practices, caring for patients through highest standards of always use best practices, effecting measurable change through a consistent commitment to patient safety. They are not failing patients who trust them to make them well. Our national healthcare system and thousands of hospitals across the U.S. are dedicated to preventing healthcare-acquired infections wherever they may occur. I am a safe care advocate, a valid eyewitness to the recent evolution of American healthcare. I am a patient and the family member of a patient. My name is Victoria Nahum.
Isn't that cool? Now tell the truth. You didn't like me at first, did you? You saw that first half and you go, really? We brought this guy over here to tell us that? But that's what we mean, change one thing, change everything. All of those words are exactly the same, except the direction. And that changes the entire message. And I love that. That video has been played actually all over the world, I can say that. So, it's great. All right. The Agency for Healthcare Research and Quality and the Center for Medicare and Medicaid Services gave us this data. I think this was in 2019. And showing the reduction in hospital-acquired conditions such as adverse drug events and healthcare-associated infections that help prevent 20,500 hospital deaths and save $7.7 billion in healthcare from 2014 to 2017. I think that's wonderful. You should really give yourself a big hand here because those are big numbers. But to somebody like me who's lost a child, I ask this question. Those are good numbers, but now what? What happens to all the other people? What happens to the rest of them? That's like saying we have a hand hygiene compliance here of 70%. What does that mean? That means 30% of people die in your hospital? Shouldn't it be 100%? I think it would. So how do we improve those numbers? What do we do to improve those numbers? In my opinion, I think we need a total system approach. And what that means is that I think 8 recommendations, and I'm not the only one that thinks this way, by the way. So here are the 8 recommendations. 1, leadership support. You have to ensure the leaders establish and sustain a safety culture, and they have to eat, sleep, walk, talk that word. It's a must. Patient safety oversight. So you have to create a centralized, coordinated oversight of patient safety because optimization of patient safety efforts requires the involvement, the coordination, and the oversight of national governing bodies and other safety organizations. About metrics. Create a common set of safety metrics. That's very important. And research. What do we do without research? address safety across the entire continuum of care, not just here, because your patients come here, you treat them, and then where do they go? Some of them go home, and everything is great, but some of them have to go somewhere else, like my son. He went to a rehab, which I never even told you that half of the story of that rehab, because they didn't even have Josh's medications, and that was 2 miles down the road. That's a whole other story. Support the workforce. It is a known fact that we have a lot of issues with our workforce across the country. There's a shortage of nurses, there's suicides, there's all kinds of problems, and we need to support them. About partnering with patients. You think that's important? I think it's very important. And the last but not least is technology, because I think technology really helps us. It's really funny because we were talking about science today in your hospitals, and I mentioned about this app that is, I kind of tested a couple of them last couple of years, and Christy says, oh, we have that. It's great. But how many people use it? That's you want to make sure that everybody uses it. Everybody has a smartphone. So, but for today, we'll be talking about partnering with patients. How did I get here? I know nothing about clinical work. I'm just a lay person. I used to be in the film industry. I'm the guy that actually allowed you to see the Olympics in 1996. I put all of those clips together for you. Every time you watch the 6 o'clock news, 11 o'clock news, all those shots and all those things were put together by yours truly. That was my job. And now, look at me. I'm in healthcare because of what happened. But I was allowed to be in this space. It just didn't happen overnight. So a lot of organizations claim that they have a patient and family advisory council or a partnership council like you have here. But a lot of places also becomes to check the box. They really do not engage their council members in meaningful work. So you heard through my short bio that I do a lot of work with this organization, MedStar Health. They are the largest healthcare system in the Mid-Atlantic between Washington, D.C. and Baltimore and Maryland. And they established their PFACs, their Patient Family Advisory Council, and we put the QS there for them because they really want to make sure that they work on quality and safety. Back in 2012, they have 10 hospitals. Each hospital has a PFAC. And I sit at the system level PFAC. So in 2015, they came to me and they said, we are launching a system-wide initiative on sepsis. Could you help us? And here's the funny part. I hear sepsis. I say yes because I do. I have a big mouth. Without thinking, I say yes, of course, because it's close to my heart because Josh died of sepsis. But then after I said yes, I was like, what, are you crazy? Like, you know nothing about this kind of work. What can I contribute to sepsis? But that's not what they wanted from me. They didn't want anything clinical. They had the clinical team. What they wanted is a new set of lenses. So they invited me to their first meeting, and there's all these big people in there, and I asked 2 questions. Because they told me that 80% of sepsis occurs outside the hospital. True? Yes. So I said, okay, let me ask you 2 questions. How long is your ED wait time? And what protocol do you use for early diagnosis of sepsis? 6 to 8 hours wait time in the ED. Are you kidding me? And 6 different protocols. So I raised my hand, of course, and I said, all right, we need to work on one thing. Eliminate wait time in the ED. And they go, it's impossible. It's impossible to eliminate wait time in the ED. I go, no, it's not. Yes, it is. No, it's not. So we fought, went back and forth. I won. There's 0 time. MedStar ED is 0 time right now. Why? Because there was a simple solution, which they told me they couldn't afford it. I said, why don't you put a tech at the front desk Somebody who takes vitals, when I come in and I say, oh, my God, I feel like I have the worst flu in my life, who cares what I say? Take my vitals. Those vitals are input into the EMR. The EMR has the protocol of sepsis. It will fire sepsis. And they go, yeah, but it might fire false positive. So? And they go, we can't afford that. I go, okay, tell me how much it costs for one case of sepsis. Oh, better yet, how much money would you put on my son's head? And there was silence. Every ED and MedStar has a tech that takes your vitals. And if you fire sepsis, whether it's false positive or not, you go in the back. You have the same priority as the person that came in with a gunshot wound. Isn't that amazing? Eliminate wait times. The second thing is that they have to do one protocol. You can't work on different protocols because as patients, I can't possibly know which hospital performs the best. It's impossible for me to know that. So we did that. And the second thing that I thought that was important to do is patient education. 80% of sepsis occurs outside the hospital. That means that 80% of this population needs to be instructed on what sepsis is all about. They have to recognize the symptoms so that when they come in, they say, I suspect sepsis. Again, I got a lot of pushback. Every ED doc said, I cannot have every patient come in here say, I suspect sepsis. And again, I reminded them how much my son cost. We designed a brochure, which was attached. See that QR code over there? That's attached to a video that we produced that has the stories of two sons, one that survived sepsis and one didn't. My son did not survive sepsis, and Lieutenant Colonel Stephen Coffey, who is part of the Georgetown University PFAC, his son survived sepsis. So we put the two of them together, and it really became a powerful video. We did a brochure to go along with it, and then the brochure and the card, which is on the next slide, right there on the left, and the video have been translated in 8 different languages now. And then we created the website to go along with it for patient education. And that's been a lifesaver. So the other thing that we did is that that's Cheryl and Paul Douglas. Cheryl is a sepsis survivor double amputee. And with her help and her husband's help, we were able to pass legislation in the state of Maryland on Senate Bill 574, which requires every single hospital in that state to have a sepsis awareness campaign. And we're trying now to do it in California and all the other states. Key strategies and lesson learned. We definitely had the leadership support. That was the most important thing. Leadership is the one that came to me and asked me to do this. And you mentioned earlier, Armando won the Sherman Award. I did not win it, truthfully. Our team won it. It does not take Armando to do this. It takes a team to do this. I'm just a part of the team. And the other important thing that I want to give you this message, and really please listen to this. If you bring an Armando into clinical work like this, you have to bring him at the very beginning of the project, because we have different lenses than you do. And if you bring us in the middle of the project, we're going to make you take 10 steps back. Year before last, the CDC came up with the TAP tools for infection prevention. They did not ask me. They did not ask any patient advocate. They just created the tools because they're the experts, the clinical. But then they asked me to be on the webinar. And what do you think happened on the webinar? I started saying, but, and they took 10 steps back and had to rework those TAP tools. You have to bring the PFA at the very beginning, patient family advisor at the very beginning. You have to have a champion who drives this, physician champion, nurse champion that drives this work. You have to have transparency. I got to tell you, you know what MedStar does with me? They allow me from my own house to log in to their server. That's kind of risky, right? But that's how transparent they are. I get to see their sepsis dashboard, and I get to see every single of their 10 hospitals, how they're performing in sepsis. It's amazing. The other thing is that if you bring somebody like me into clinical work, It's important to allow us to be creative, allow us to think outside the box. We don't think like you. You have all that medical knowledge. We don't. But together, it's like magic. MedStar believes in that. It's becoming, the sepsis MedStar model has becoming, it's going all over the country. I'm getting calls from other organizations as big as yours and bigger. They're saying, how do we bring in Armando into this kind of work? Well, you give me more credit than I deserve. There's thousands like me all over the place. You haven't found them. They're right here in your organization. So, on that note, I'm being told that I talk too much. I have to. So I'm going to, spend some time later on in the Atrium with some of you, and we can chat a little bit on this thing. So I'm going to introduce you to a very special person. Her name is Kathy, who has partnered with Cleveland Medical Center under Partnership Council for the last few years. And to better show you what I'm talking about, we get this out of here.
Talk very loud. So, for those of you who don't know me, my name is Robert Hughes. I have the pleasure of serving as the chair of the System Sepsis Initiative. I have a big slide deck, but frankly, we don't need slides. What we need to do is we need to leverage the power of connection. And so I want to thank Armando, I want to thank Kathy, I want to thank Chrissy for putting together an amazing presentation because, frankly, apparently I need the mic for the recording, so thank you. So again, my name is Robert Hughes. I'm the chair of the System Sepsis Initiative. But to get back to where we were, we don't really need slides. We need personal connection. And we need to understand that it is our relationships that are what drive healthcare. We all want to do a good job, and the system should exist to support that good job, should exist to make easier the job that we're trying to do, which is to care for patients. So first what we're going to do is we're just going to talk a little bit about history, but I would be remiss to not mention some very key people who have helped in this initiative. This list is not exhaustive. There are a ton of people who help with this initiative. I just happen to be standing here right now talking to all of you. We're going to discuss sepsis as a clinical entity incredibly briefly, but what I want to focus on is our data and then what we are doing, future state, and looking forward. So, a very classic presentation of a person with sepsis. A pneumonia, something simple, vital sign abnormalities, a fever, tachypnea. We have all seen this person. Bandemia, white blood cell count, chest x-ray with the right basilar consolidation. We know what to do with this. We know to treat it with antibiotics. We understand that what really ends up happening with sepsis in terms of cascade is this uninhibited immune response that turns into this dysregulated host engagement on itself and causes this run-of-the-mill infection, a normal UTI, a normal pneumonia, to become something bigger that results in multi-system organ failure and subsequently potentially bad outcomes and possible death for our patients. So we have a couple different ways that we diagnose sepsis, and this is where the true challenge comes in, and I think it was illustrated very well with our patient family partners who came up here to speak. In the emergency department, even ever vigilant, knowing that somebody coming to me might have not only a pneumonia but potentially sepsis. 80% of our septic population is captured immediately on arrival to emergency departments across our system, but there's 20% that's not. So even with shifting diagnoses in the medical community, SOFA, finding that organ dysfunction, Q-SOFA, independent mortality predictor for our patients if they have 2 out of 3 of these, which makes sense. Sick is sick. But how do we find people before that happens? How do we target the 20% that are in the hospital that are post-op day 3 for MNAPI? How do we find the person who is in the rehab process who's a little short of breath and developing a nosocomial pneumonia? That's the trick, and that's what's really hard. We all have a lot that we're trying to do, a lot of good for a lot of people, and it's very challenging. And I think, speaking to relationships, leveraging that patient-family partner relationship, understanding that we have eyes on our patients at all times, whether we know it or not. The Q24-hour vitals, the Q-shift vitals are actually happening more than we ever realize it because moms and dads and sisters and brothers and friends and family know how their family members are, and we need to leverage those relationships to help identify the 20% that might be hiding. So I'm not going to go into too much detail about how we get here, but we learned a couple lessons in 2001 by a study done by Emmanuel Rivers out in Detroit, and what we learned was that aggressive care of the septic patient is vital, but we didn't know what components of that aggressive care were vital. We knew that we had almost a 16% reduction in our mortality when we had what was called early goal-directed care. So let's fast forward and try and find out what helped. Well, we had 3 trials come out between 2014 and 2015, and I think we're all aware of the process trial that was done here in the United States, and the long and the short of it was, let's look and see what of those interventions really helped. Well, what ended up happening was there was no 90-day mortality difference. We did all these aggressive things. We did usual care. We did early goal-directed care, and there was no difference in mortality. But I would argue that there, in fact, was a difference in mortality. Our usual care by this time, as shaped by Rivers' work, was that we need to be diligent, we need to be aggressive in therapy, and we need to identify septic patients early. And so we have found out that antibiotics are helpful, that early surveillance and detection is helpful. This is what truly helps our patients. Now let me tell you about the Sepsis HRM initiative, because this is the meat of where we want to go with this. We have done a lot to standardize what we do for sepsis: education, feedback, and data analysis. We have spent the past calendar year, maybe 18 months, enhancing our EMR experience so that we now have a set standard, to Armando's point, a way of approaching the septic patient. We have one set standard order set. It does not matter if you are 3 days after the appendectomy. It does not matter if you were presenting to my emergency department today with cough, congestion, fever, and chills, and you have a pneumonia. We all now use the same order set: sepsis initial management, rapid access to antibiotics, things that we know help. We've identified a way to optimize our order set so that we can make the process of caring for patients as automated as possible, so that you all can be at the bedside, so that you could be with your patients, be with your patient's family, surveil for progression of their disease. This leads to our HRM for innovation. If any of you are interested in joining the HRM, the more brain power we can have, the bigger we can make this brain trust, the better this is going to be for all of us. Because the reality of sepsis is there is not a person, not a service line, be it surgery, be it neurology, be it psychology or psychiatry, that this does not affect. It affects everybody. It is not just a disease of the emergency department. It is a disease that presents whether somebody is post-op day 3 or they are in their rehabilitation or they walk through the front door of the ED. To that end, we need to all be diligent and we need to foster those relationships. And through innovation, we develop patient-centered care, which feeds back into our consistent vigilance with data analysis so that we can optimize this process. So our keys to success are early rapid identification, rapid action, and making things easy for you all so you can be at the bedside taking care of your patients. And these were the goals. This is a busy slide, but it is to illustrate the amount of work that has gone into developing a standardized process and where we will take this moving forward. But more importantly is what we are going to be doing. I want to really focus on the patient and family engagement because, again, this gets even harder when all of a sudden you don't have 2 nurses at the bedside, a medic and the tech, me at the bedside in the first 10 minutes of somebody presenting to the emergency department. On post-op day 3, it is harder when they are getting Q12, Q24 vitals, and we need to leverage these relationships so that we can be ever diligent in identifying the potential septic patient. Some of our data, because I'm very proud of this, and this is what has culminated from a lot of hard work. So moving leftward on this chart is improvement. Okay, so the orange bars are showing our observed over expected mortality. So people come and they are sick. We all know this. We have patients who have multiple medical comorbidities, and we have patients who become septic. And those patients have a higher propensity for getting ill on us. But we are driving this lower and lower. And specifically, we look at our mortality. Here's February through January. We're already getting rapidly close to our target. Once we exclude our transfers and we look at our university hospitals, community sites, our mortality is below our 8% baseline already, and we're driving it ever lower. And then here's our mortality as we exclude our transfers and our hospice patients. The people who are sick come to CMC Maine because we're a quaternary care center, and that makes sense. But this is putting more of an apples-to-apples comparison. We're doing a good job, but the job is not done because the job now requires our journey to start today. So I want every one of you, when you see an infection, when you see a patient who is sick, for you to say to yourself, why is this not sepsis? Why is it a run-of-the-mill pneumonia? Why is it a run-of-the-mill UTI? Think sepsis. Embrace the concept and then wheel yourself back. We do the same thing for STEMIs. We do the same things for strokes. And we have saved lives because of that. So what are we doing in 2020 and beyond? Well, we're embracing that relationship with our patient-family partners. We're going to continue to use the order set so we can cognitively offload the things that we don't need to worry about. You shouldn't have to worry about ordering a repeat lactate to check a box. So that's automated in the order set. You shouldn't have to worry about the blood cultures coming with a message to your nurse to obtain those before they give the antibiotics. The order set does that. You shouldn't have to worry about a communication to your nurse to say, hang the broad-spectrum antibiotic first. The order set takes care of that. So you can do the things you need to do, which is to engage your patient and engage the family. So this is something that we've partnered with Stroke to develop a family partner engagement, a Think Sepsis, a Think Stroke. It's going to be distributed across the hospital. It's going to be hung and be available. We've already talked about our 2020 initiatives, and to Armando's point about leveraging technology, we are partnering with comparative analytics and trying to build a repository of data analysis to minimize our alert fatigue and to maximize our potential surveillance for sepsis before it happens. So keep your ears peeled because more to come. And so our sepsis HRM depends on rapid recognition, aggressive treatment, and continued surveillance, although I would be remiss to not mention that I left off a very key component of this, and that is to foster the relationships that we have with our patients and our family partners. And with that, I want you to think sepsis. I want you to use the order set because hopefully we made it easy so that you can do the thing you need to do, which is care for your patients. And I want you to join the initiative. So thank you so much for having me. I kept you on time. How's that? And it was a pleasure to be invited to speak. Oh, guys, we'll be down in the Atrium to field questions if you have anything.
I just want to thank all of our speakers. Any last message? Use the order set. Order set. Order set.
But I want to be clear. So as a person who actually is not a fan of order sets, that's how you know this was designed with that in mind. The order set is meant to make things easier for you. It is not meant to supplant medical decision making. It is not meant for you to say, hey, I have a patient who I think has coronavirus or flu. We're going to be entering a phase of medicine over the next couple of months that is going to make this initiative challenging. I wasn't going to bring it up, but I think it's prudent to say diligence and vigilance are going to be incredibly important, especially over the next couple of months. It's something that we've always sort of had in the back of our heads, but I want you guys to know that there is a system in place to support you. The HRM exists. I'm available by email whenever you need, just robert.hughes@uhhospitals.org, and the HRM should hopefully make this process easier for you.
And I've been involved very peripherally. It takes a lot of time and effort, and Dr. Hughes has really pushed this, so.
Thank you. Thank you.